Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate with MAVEN Project. Thank you for joining us today and our friends at Generations Family Health Center for hosting today's session, Lyme Disease New IDSA Guidelines on Diagnosis and Treatment with Dr. Lawrence Zemel. And with that, it's all yours.
Thanks, Jennifer. And as Jennifer indicated, we're going to talk about Lyme disease today. I have nothing. Hold on a second. My slides are not advancing. Let me just go back for a second. We'll exit the slideshow and go back in. There we go. So I have nothing to disclose, and accreditation, Jennifer already discussed that. And the objectives of today's talk is to observe the clinical features of Lyme disease that would help you make a diagnosis and review the latest guideline recommendations, particularly around treatment. And also I'll discuss some of the controversy particularly related to some Lyme advocacy groups. There are a number of references, which I'm not going to go over right now, but I'll draw your attention to the clinical practice guidelines that was published in 2021. I was a co-author of those, and these will be up on the slides that will be saved so you can refer to these references. And I'll start this talk with my conclusion. So in conclusion, Lyme disease is straightforward to diagnose, and treatment schedules are fairly well established. But as I mentioned, it's also a somewhat controversial topic in some quarters of the country, being politically charged, and some of the lay lobbyists are trying to dictate health policy, and we'll get into that shortly. So we'll start with a case, and this is an 8-year-old boy from the shoreline of Connecticut, from Guilford, in fact, who came in with a very swollen left knee of 2 days duration. There was no prior trauma. He had no fever, recent strep, rash, any ocular complaints, but he did have what was thought to be a viral illness in June 2020. Well, actually, this is an older slide. So for the sake of this talk, let's say it was June 2024. And at that time, in June, he had fever of 102, some chills, neck stiffness, headaches, and myalgias. So at this point, do you refer to orthopedics, aspirate the knee, order appropriate lab studies, and start amoxicillin pending the lab results because you suspect that he could have Lyme disease, x-ray the knee, all of the above? And my answer, at least, is ordering appropriate lab studies and starting antibiotics pending the results. And we'll talk about a choice of either amoxicillin or doxycycline a little bit later. His labs that came back indicated a slightly elevated SED rate, and his Lyme ELISA was positive at 5.2 units. And keep in mind that low positive results like 1.2, 1.3 are usually false positive results. And the Lyme Western blot, or the immunoblot, can sort out true positives from false positives. And so in this case, using a commercial lab, which tests for 10 different proteins or antigens on the spirochete, he tested positive for 9 out of 10, a strongly positive test, which is classic for late Lyme arthritis. We'll talk about that shortly. As you know, IgM is the early reaction, but in many cases, IgM antibodies will hang around for a while, so we don't pay that much attention to the positive IgM. And so this brings us to a case definition of Lyme disease. And this goes back to 1996. And there have been some modifications over time, but essentially it's really the same. And that is Lyme disease can be diagnosed either by observing the Lyme rash, erythema migrans, which I'll show you, measuring at least 5 centimeters across. No laboratory confirmation is required. If someone has a classic erythema migrans rash, or one of the later manifestations, along with laboratory confirmation of infection. And I've listed some of the late manifestations, include episodic, that is, episodic arthritis of large joints, mostly the knee. Carditis, heart block mainly, rarely myocarditis, and certain forms of neurologic disease, most commonly seventh nerve palsy, but also a so-called aseptic meningitis, and other cranial nerve palsies can occur as well. Excuse me. The footnote at the bottom is an important statement. And this is from the CDC, that is IgG seronegativity in an untreated patient with at least 2 months of symptoms essentially rules out the diagnosis of Lyme disease. So that I mentioned you can sometimes see a false positive test. About 10% of initial screening tests are low false positive, but we rarely see false negative results in established untreated Lyme disease. Patients in the first few weeks of, within the first few weeks of exposure to a deer tick may test negative until IgM antibodies are detected, usually by 2 to 3 weeks. And in this world map, you can see the different types of ticks that we find, different species in Northeast and the Midwest, the upper Midwest. The deer tick, or Ixodes scapularis, is present out west, Ixodes pacificus. And then there are other species in other parts of Europe, Asia, and even North Africa. And if we focus on our country, and most of you are aware of where Lyme disease is most common, that is the Northeast. You can see here, Connecticut is just chock full of Lyme disease, Michigan, Minnesota, Upper Peninsula. And in this map, which is actually from 2022, virtually every state, or just about every state, is represented. But some of these states in the Southwest and Rocky Mountain states where there are no deer ticks, most of these isolated cases are patients who had traveled to Lyme endemic areas, visiting their grandparents in the Northeast. And when you look at different ticks, the black-legged tick or deer tick in the Northeast is responsible for Lyme disease. And here you can see the relative sizes compared to a dime, and the scale over here. And the larval tick, which is not infected, which emerges from the eggs, is about the size of a pencil point. And once this feeds, often on a white-legged mouse that may or may not be infected with spirochetes, then it changes or molts into the nymphal stage. And the nymphs are avid feeders. And about 25% of these nymphs are infected with spirochetes. Each stage takes one blood meal. Nymphs may feed on other mammals, birds, mice, and humans. We're accidental hosts. And then it molts into the male or female tick as well. In Connecticut, 54% of adult females are infected with spirochetes. So that incidence of infectivity has actually risen over the last decade or so. By comparison, you can see the Lone Star tick here with that distinctive pale marking on the dorsal surface, and the dog tick, which does not carry spirochetes and is not at risk for Lyme disease. I'm not going to discuss it very much, but Lone Star tick, which has now entered southern Connecticut and Fairfield County, poses a risk for so-called alpha-gal syndrome, which can produce pretty severe red meat allergy. That is, the Lone Star tick may feed on a deer and pick up this galactose molecule. And then when the Lone Star tick feeds on a human and transmits the alpha-gal molecule to the human, and a cascade of immune reactions takes place, and that can result in a sensitivity or allergy to red meat. The adult females are avid egg layers. You can see here the number of eggs that are expressed during one season. And the spirochete, which was first discovered in 1981 in the Rocky Mountain Laboratories in Montana by Willy Bergdorfer, and hence the spirochete has been named after Dr. Bergdorfer, and it's referred to as Borrelia burgdorferi, as most of you know. And this is a magnification of 500 times. Now, if an infected tick is feeding on a human and the tick is not removed, it's undetected, within 3 to 20 or 30 days, a rash may appear, erythema migrans, at the site of the tick bite. And these are some examples of erythema migrans. So this is a mature rash. It's about 12 centimeters across. You can see the central clearing. And as the annular lesion expands outward, the border tends to fade. But in general, the border is fairly well defined. It's not raised. It's relatively asymptomatic, except for maybe some mild warmth. This is the so-called target or bullseye lesion, which is less common. And then some patients may have uniform erythema. And I'm not showing here a necrotic center, which resembles a spider bite, can also be seen as well. So not everybody develops the Lyme rash. About 2/3 of patients will develop erythema migrans. And so I said about 40%, but that combines both nymphal ticks and adult ticks. And the Ixodes pacificus out west has a much lower infectivity rate. As I mentioned earlier, classic rash does not need lab confirmation and should be treated accordingly. And I'll go over the treatment schedule. And if you're not sure about the rash, you can always get an acute titer, although initially the lab work will be negative. But then you can wait a few weeks and get a more convalescent titer. Culture is difficult, and nucleic acid testing, like polymerase chain reaction, is not advised on the skin lesion, but it is used in experimental studies as well. So what are the symptoms of early Lyme disease? In addition to the rash, which may be solitary, or it may end up as multiple lesions, you can see headaches, low-grade fever, 101 perhaps, myalgias, arthralgias, flu-like symptoms mainly. Abdominal pain is common as well. And here's an example of multiple erythema migrans skin lesions. Now, this represents bloodborne dissemination. So these are not multiple tick bites, but rather there's a seminal erythema migrans, and from that site, spirochetes will enter the bloodstream. And in addition to multiple skin lesions, can also cause other disseminated symptoms within a few weeks of exposure, including signs of meningitis, cranial neuropathies, as I mentioned, especially seventh nerve palsy, which is actually in Lyme disease not appropriately referred to as Bell's palsy. That term, which is actually now Bell palsy, refers to idiopathic seventh nerve palsy, not one related to a known cause. Some symptoms of heart block may occur, and again, one can see fever, low-grade fever as well. Later Lyme disease may result in the arthritis, which is episodic. It can start out with one knee, disappear, and then days or weeks later occur in the other knee or ankle or shoulder, elbow or hip. About 10 to 20% of children will develop a persistent arthritis, which is no longer infectious. And we'll talk a little bit more about that in a moment. I've seen a number of cases of low-grade encephalopathy. I've done a number of LPs during my time treating Lyme disease, and it's useless to try to culture the bacteria at that point, but we sometimes do see positive PCR reactions, or sometimes we'll see a positive Lyme index, IgG index, where you have higher titer antibodies in the spinal fluid compared to the serum. And then one other feature of late Lyme disease, which we'll talk about, is post-treatment Lyme syndrome, or what some people refer to, or at least what I refer to, as long Lyme, because of the similarities to long COVID. Now, so the arthritis of Lyme disease is very distinctive in the knee especially. It produces the largest joint effusions of any rheumatic disease, often exceeding 100 milliliters within the knee. Joint aspiration is not necessary for diagnosis because the blood test is always positive in Lyme disease. So that if you see a child or an adult with knee swelling and the blood work is negative for Lyme, start looking for other causes of arthritis. Sometimes the fluid from the knee joint, because it's under such large pressure, will rupture posteriorly and then travel down the calf along the fascial planes of the calf, causing pain, swelling, occasionally some erythema of the calf. And we refer to that as pseudothrombophlebotitis. And this is an MRI of the knee. You can see here, one second. And on the coronal view, you can see the fluid tracking down the calf, and the corresponding axial views here show the joint effusion within the knee. And if you go further down, you can see some edema and fluid as well. So this is the one time where an MRI may be useful in managing a patient with Lyme arthritis of the knee. Hold on, again, I'm having some trouble advancing the slides. Um, so diagnostic testing for Lyme arthritis is mainly doing the serologic test. And we still use this so-called two-tier testing, where the first test is an automated ELISA test. You can run multiple samples at one time. It's inexpensive. And that usually combines both IgG and IgM and gives you a number like 2.6 or 3.2. And as I mentioned, lower level tests, lower level positive tests like 1.2, 1.3 is often a false positive test. But then if the lab finds a positive test in the first tier test, then it reflexly or automatically will run an immunoblot or Western blot on the same sample, and then that will confirm whether this is a true positive test or not. And then, as I said, all patients should test positive for IgG antibodies by the time arthritis develops. It's not necessary to test synovial fluid unless you're not sure when someone comes into an emergency room with a swollen knee and does indeed have some fever as well. And now you're not sure if this is Lyme disease or could it be a septic joint. Crystal arthropathy could be seen in adults, not so much in children. And in that case, you may need to analyze and culture synovial fluid and may even start somebody on appropriate antibiotics for septic arthritis until you get back the Lyme serology and your culture results. Rarely PCR is necessary. Now, under normal circumstances, there is no role for an MRI in Lyme arthritis, except for that one case of pseudothrombophlebitis of the calf. Now, neurologically, one can see involvement of either the peripheral nervous system or the central nervous system. And so peripherally, I already discussed seventh nerve palsy, third nerve, optic nerve can sometimes be involved. Sometimes we'll see papilledema in Lyme disease. You can get radiculoneuropathies, that's more common in Europe, mononeuropathies, and the CNS involvement may include meningitis, raised intracranial pressure, and encephalopathy as well, that may represent direct bacterial invasion of the brain, or it may represent inflammatory mediators like cytokines tickling the brain and causing a transient encephalopathy. Myelitis is not usually seen in this country. Now, there's been some debate about whether or not one should use steroids if someone comes in with seventh nerve palsy, say someone comes into the emergency room. And basically, it's okay to start somebody on steroids while you're waiting for your Lyme serology to come back, because steroids are not going to really terribly interfere with Lyme disease and response to antibiotics. But it can make a difference in Bell palsy. So that's why you should start steroids promptly when you're not sure yet. And then some people claim that psychiatric disease could be caused by Lyme disease. But when we reviewed the literature and we looked at this very carefully, we concluded that if an adult presents with psychiatric illness, testing for Lyme disease is not necessary. And likewise, children who have developmental, behavioral, or psychiatric disorders, routine Lyme testing should be avoided as well. Let's talk a little bit about Lyme prevention. So there are some personal prevention measures. So starting on the left, avoid risky habitats. Well, I'm not sure about that. I'm an avid hiker and I go out in the woods all the time. Although if you're walking in the center of a wide trail, generally you're not going to get exposed to ticks who tend to land on you as you walk through shrubs and low-lying trees. Long sleeves, long pants are helpful. And if you're really concerned about ticks, you can treat clothing with permethrin, not on your skin, but on your clothing. And on your skin, you can spray a DEET containing insecticide. And afterwards, and this is really the critical thing, you're going to do a tick check after you come in from potential Lyme exposure. Because if you can remove a tick within 24 hours, you're not going to get Lyme disease. Bathing or showering is helpful because if ticks have not attached yet, a shower could easily dislodge a crawling tick. Some people recommend drying your clothing on high heat to get rid of any remaining ticks in clothing. That may be taking things a little too far. And these are some of the different insecticides or repellents that can be used. I still tend to prefer DEET, 20%, 25% DEET, like Deep Woods Off, cutters, those kind of things. And vaccines have been developed, just to go back, the first vaccine by Edward Jenner was in 1796, when he discovered that milkmaids who developed cowpox, a milder illness than smallpox, never developed smallpox. So when he gave cowpox to a neighbor's son and then exposed the son deliberately to smallpox, we can't get away with this today. That child did not develop smallpox and recovered completely. But in more modern times, mRNA technology, as you know, has been used for COVID vaccines. And we actually did see a transient Lyme vaccine called LymeRix, which was approved in 1998. There were 3 different shots in the first year. It was manufactured by GlaxoSmithKline, and it was probably about 80% effective. So it did work. And initially, Lyme advocacy groups were excited about getting a vaccine. But as some people complained about some joint pains as a result of the vaccine, there was some sort of increasing publicity. And eventually, the same Lyme advocacy groups started collecting so-called cases of vaccine reactions. And some of them were completely unrelated to the vaccine. Some people developed persistent arthritis and other complications. And so as a result, groups are now threatening the manufacturer with mass action lawsuits. And GSK threw up their hands and said, we don't need this. We're not making enough money on these vaccines to handle potential lawsuits. So they got out of the business. So after 2 years, there was no vaccine. But now there is ongoing work. Valnexa, a French company, is now in phase 3 clinical trials of an anti-outer surface protein A antibody, giving the antibodies to patients, which will then basically go into the tick. As the tick is feeding, these antibodies will neutralize the spirochetes directly in the tick. And then there are a more conventional vaccine that's being developed as well in early stages of development. Ed McSweeney was a respected Lyme researcher working at NIH, and he basically stated publicly that people found online activist websites filled with misleading information about the vaccine, personal vaccine victim stories, and news group bulletin boards offering a repetitive stream of misinformation, libel, and quack treatments. He wasn't pulling any punches. The public opinion battles over Lyme were fought and lost in cyberspace. And obviously, misinformation is continuing and getting worse in this very day. Now, if your patients are bitten by a tick, you can submit the tick for species identification to be sure that this is a deer tick. In general, it's not necessary to test the tick for the bacteria, although you could. And if following a tick bite, patients are asymptomatic, they don't need to be tested routinely. Now, what I like is if a tick has been attached for at least 24 or 36 hours, and you know it's a deer tick and you live in a Lyme endemic area, you can take a single double dose of doxycycline, 200 milligrams, and that's extremely effective in reducing the risk of Lyme disease. But the likelihood of Lyme disease occurring after you remove a deer tick is pretty low, maybe up to 3%. Now, this is a graph showing determining when in mice the bacteria is transmitted from the tick to the mouse. So if you follow this from 0 hours of attachment up to, say, 31 hours, and mice are being tested and sacrificed at various intervals, you can see that mice are now first registering infection after probably about 35 hours of tick attachment. And 50% of mice are infected by 60%, by 60 hours of attachment. So the take-home message here, at least in mice, but we assume it applies to humans as well, that below 30 hours of attachment, if you remove a tick, certainly within 24 hours of attachment, the risk of Lyme disease is fairly zero. And now, there are other pathogens that can be carried by the same deer tick. Powassan virus, for example, is rare, but if the deer tick is carrying Powassan virus, that's transmitted within an hour, and that has a certain mortality rate. Fortunately, it's very rare. Removing a tick from the skin is you take tweezers or forceps or some such device, and you attach these tweezers to where the tick is attached to the skin and pull straight up. Don't worry if there's a bit of the mouthpiece still within the skin, because in general, that's not going to contain the bacteria. The bacteria is found in the midgut. So if you get out most of the tick, then you will prevent Lyme disease, again, if you remove the tick within 24 hours. We'll talk a little bit about antibiotic treatment of Lyme disease, but I would just point out that these tables are readily available. This comes from the guidelines that's listed in your references. You can find this in the Red Book or virtually anywhere. So here's the bottom line of treating Lyme disease. There are really 3 medications that you need to remember. One is doxycycline, one is amoxicillin, and one is ceftriaxone intravenously. So doxycycline and amoxicillin given orally for either the rash or seventh nerve palsy, for a low-grade heart block, and initial treatment for arthritis. Doxycycline and amoxicillin are relatively interchangeable. Children now, young children, can safely receive doxycycline as well, so we no longer withhold doxycycline from a 2-year-old or 3-year-old. There is a liquid form of doxycycline. The one difference, or two differences, I should say, is that if you're treating somebody in the summertime, and let's say a teenager is playing soccer on a soccer team and is exposed to the sun frequently, then you may want to avoid doxycycline because of the risk of photosensitive reactions and rather use amoxicillin. Doxycycline has better CNS penetrability. So if you're treating one of these manifestations of Lyme disease and patient is complaining of headaches, maybe a little confusion, but no frank meningitis, you may be more inclined to use doxycycline than amoxicillin. And this is the dosages. Again, I'm not going to discuss that now because these dosages are readily available. Now, I mentioned earlier that sometimes, in perhaps 10 to even up to 20% of cases, Lyme arthritis can persist despite oral plus intravenous antibiotic therapy. So if after initial treatment with oral antibiotics, if there's still some swelling, you can wait a little while and see if the swelling is reduced on its own. But if not, you can consider either a second course of oral antibiotics, or if there's no response whatsoever, you can go right to intravenous ceftriaxone, usually 2 to 4 weeks. So the point here is that the longest duration of antibiotic therapy that we recommend is perhaps 2 months, 2.5 months, and that would combine 4 to 6 weeks of oral therapy, 2 to 4 weeks of intravenous therapy for persistent Lyme arthritis. After 2.5 months of antibiotic therapy, there is no further benefit of additional treatment. But there is, of course, additional risk of drug side effects. And the longer, of course, you use antibiotics, you're not only disturbing the microbiome and all of the late effects of that, but if you're using a PICC line for several months, the risk of PICC lines, infection and sepsis, gallbladder disease from ceftriaxone, and so on. All of those risks from antibiotics. Now, Lyme arthritis may persist despite 2 months of antibiotic therapy. And what's happening here is that the arthritis has now switched from an infectious arthritis to an autoimmune arthritis. And so we recommend that you don't give additional antibiotics, but rather you start, or rheumatologists would start, disease-modifying drugs, such as methotrexate, or give intra-articular steroids, which can be very effective. Even use some of the biologic agents, such as Enbrel or Humira. We performed, the number was about 6 arthroscopic synovectomies in kids who had persistent Lyme arthritis despite antibiotic therapy. And when we gave patients a choice of arthritis medication versus a surgical approach, some of the families actually preferred the one-time surgical approach, which was 80% effective. We'll use NSAIDs such as naproxen or celecoxib or meloxicam for pain management, but that doesn't have any real curative role or even arthritis reducing role in this case. If a pregnant woman develops Lyme disease, she can safely be treated with beta-lactams such as amoxicillin or cephalosporins, but we tend to avoid doxycycline. And this is a quote from the guidelines that Lyme disease in pregnancy has not been found to result in congenital infection or a syndrome of congenital abnormalities when the pregnant woman is appropriately treated. Now, the literature has, an older literature from the 80s, has several cases of congenital infection in women who had not been treated. This is when treatment was not yet recognized to be effective. And basically, the congenital infection resulted in neonatal death. I also mentioned earlier a so-called post-treatment Lyme syndrome or long Lyme. And let's just focus on the left side. And inclusion criteria for post-treatment Lyme syndrome includes documented Lyme disease. That is, you have clinical and laboratory evidence for previous Lyme and documented completed therapy adequate for that stage of Lyme disease. And now you've developed subjective complaints, non-specific complaints, such as fatigue, joint and muscle pain, brain fog, sometimes radicular pain emanating out of the spine, all within onset of 6 months of the diagnosis of Lyme disease and persisting for more than 6 months after completion of antibiotic therapy. Additionally, it results in some functional impairment, either at work or in school. And post-treatment Lyme syndrome can last 1-2 years, in some cases even longer, and it's just treated mostly symptomatically. But we feel that this is a post-infectious complication of Lyme disease. Now, some patients say that they have chronic Lyme disease. And, I slightly bristle at this term because Lyme advocacy groups or maverick physicians, or a small group of physicians who say that if somebody has persistent symptoms, they should be treated for months and years even. And I've seen some of those patients. And these can be subdivided into 4 categories. And we published this in the New England Journal a number of years ago. So category 1 are medically unexplained symptoms. Somebody has chronic headaches, let's say, where all studies are normal, we don't really have a good explanation. And there's no evidence of Borrelia burgdorferi infection. And yet patients believe they have Lyme disease, and they may find a physician who says, yeah, I don't believe in the tests, but headaches, classic symptoms, you have Lyme disease. Category 2 is a patient who has multiple sclerosis or rheumatoid arthritis or some other well-defined illness completely unrelated to Lyme infection. And they test negative as well, but the patient feels that their symptoms must be Lyme disease because they live in Connecticut. Category 3 are medically unexplained symptoms, but they do have low-level antibodies. They never had a history of erythema migrans or Bell or seventh nerve palsy that would be consistent clinically with Lyme disease. But this is a tricky category because roughly 10% of people who live in Lyme endemic areas, think Nantucket, Martha's Vineyard, Crane Beach, North Shore of Massachusetts, and all of these areas have had serosurveys which show that about 10% of healthy people who never had Lyme disease test positive for Lyme antibodies, meaning that they've been exposed, but successfully fought off Lyme disease, never developed it. So here you have medically unexplained symptoms, positive antibodies. You're obligated to treat these patients, but what I do is I tell them, I don't think you have Lyme disease, but let's treat anyway, and there may not be a response. And finally, category 4 is what I just described as post-Lyme disease syndrome, and we prefer a term like that rather than chronic Lyme disease. Now, I keep on alluding to these Lyme advocacy groups, and they have a playbook. They have a certain strategy or set of strategies, which includes unfiltered web-based information and or misinformation. They provide public testimony, where they're trying to, well, they're raising awareness for sure, but they're also trying to overdiagnose Lyme disease. Public testimony tries to direct money toward certain groups and certain physicians. They conduct scientific meetings, but they will only invite physicians or scientists that subscribe to their point of view, which often includes long-term antibiotic therapy and departure from standard criteria for diagnosing Lyme disease, liberalizing criteria. So more people are diagnosed with Lyme disease. I'm not sure why they want to do that. They will lobby NIH and legislators. They will personally attack physicians who are mainstream and try to adhere to the science. Their websites, and their websites are beautiful. They're very polished. They have physician referral services, and they will refer to sympathetic physicians that are referred to as Lyme literate doctors or Lyme MDs. And they will also try to protect these LLDs from prosecution because they often overdiagnose and overtreat Lyme disease. And I've reported a number of these physicians to local health departments, particularly in Connecticut and New York. One good example of how these groups personally attacked physicians involved Dr. Alan Steer, who first described Lyme disease in Connecticut in 1977 with his publication while he was both a rheumatologist and epidemiologist at Yale. And he received a report from a parent in Lyme, Connecticut, of 3 family members of her family developing sudden onset arthritis, and 10 families on her street with the same type of symptoms. And so he investigated this phenomenon, and he studied 3 towns in Connecticut along the lower Connecticut River Valley. And Alan Steer published his report in Arthritis and Rheumatism in 1977, the same time that I arrived in Connecticut. And he described 39 children and 12 adults with this unusual form of arthritis. And he went on probably to publish 120 publications, starting while he was still at Yale, and then continuing while he was at Tufts, and finally ending his career at Mass General. But while he was at Tufts, he would see patients for second opinions, and some of the patients he saw were those first 3 categories of patients who thought they had chronic Lyme disease, but did not in fact have Lyme disease, and he would not treat them. Some of these patients became angry and threatened him. And so Alan had to place his lab at Tufts under lock and key and hired a security guard. And so here, this champion, this hero of mine, by adhering to the science and not giving in, not caving to the misinformation, was being threatened by. But to his credit, he continued to investigate, and he devoted the latter part of his career to understanding the immune mechanisms involved, particularly in persistent Lyme arthritis. Now, just to give you an idea of some of these websites that are producing false information, a colleague of mine, Hank Fader, sorry, 20 years ago, looked at 19 different websites here. And some of these are, very legitimate websites, like the American Lyme Disease Foundation, CDC, FDA, and so on. And he and a resident, Jay Cooper, asked these websites, or investigated whether these websites answered 8 standard questions that there's a standard answer to, about breastfeeding, treatment, transmission, etc. And so, and he graded, Hank Fader graded these websites either A for accurate or I for inaccurate. In some cases, the websites did not address that particular question. So, for example, Johns Hopkins was accurate in 6 of the 8 questions that it did address. And you can see the accurate websites. But you move below, like the Lyme Disease Association, LDA, every single question that was asked was answered inaccurately. And then you go to IGeneX, which is up here. One of those questions was not addressed, but 7 out of 8 was answered inaccurately. And that's significant, but because some of these, I'll say politely, maverick physicians who do not adhere to standard guidelines, either for diagnosis or treatment, send blood samples out to IGeneX in Palo Alto, California. Why do they use IGeneX? Because that lab is much more likely to produce a positive test result. They use their own criteria, and they've been investigated by California Department of Public Health. As far as I know, they're still in business. But when I see a patient coming in carrying an IGeneX lab report, I explain to the family, I show them literature where they've been discredited, and I go to more conventional laboratories or universities for testing. And so let the consumer be beware. You have to kind of know the website that you're looking at and what's your source of information. Unfortunately, today there's so much mistrust of certain websites and of mainstream physicians that sometimes it is difficult. And I'll end here and take any questions that you have.
All right, we do have a couple questions. Let me see, there's one in the Q&A. I have patients that have multiple deer tick bites each week. Is there a protocol for weekly doxy 200 milligrams or something similar for prophylaxis instead of with every bite? Thank you.
We've recommended that occasionally in a setting, in a scenario, just as you're describing. And so we've generally used amoxicillin twice a day, low dose, 250 to 500 milligrams twice a day. There's very little scientific data, documenting the effectiveness, but in my experience, that can work rather than doing a double dose of doxycycline with every tick bite when somebody's being exposed that often.
And then we have another question in the chat. Can you comment on the use of bee venom for chronic Lyme disease?
The short answer is no. As far as I know, there is no proof that bee venom is effective. Bee venom has been tested in rheumatoid arthritis, and there's been some mixed results in rheumatoid arthritis. But, when you say chronic Lyme disease, again, that gets back to the term, are we talking about post-treatment Lyme syndrome, or is somebody still infected? In either case, we really have no proof. So it's probably not harmful other than the pain of the bee sting.
Okay, another question. Any experience yet with Lottie Lanner?
I'm sorry?
I don't know if I'm saying it right. Any experience yet with Lottolaner? Lotilaner?
Oh, I'm not familiar with that, so I can't comment. I'm sorry.
Okay. Um, and someone asked best online sources for current incidence and rates of Lyme in particular states.
CDC. The CDC has a table of the most affected states. Actually, I didn't include that slide, but right now, if you're looking at Lyme prevalence per 100,000 people, Rhode Island wins the prize. Rhode Island has the highest prevalence of Lyme disease, about 200 cases per 100,000 population. Pennsylvania wins the race for the most overall cases of Lyme disease because it's a larger state. But the CDC has maps and tables, and it's up to date.
Whereas CT recommended prophylaxis for tick bites, I believe New Jersey did not. Is it worth and does it interfere with serology in the future?
Read that question one more time.
Whereas CT recommended prophylaxis for tick bites, I believe New Jersey did not. Is it worth it and does it interfere with serology in the future?
Um, well, I'm not sure. And when you say New Jersey is not recommending it, um, I don't think states are passing legislation or codifying whether or not, Lyme disease should be treated prophylactically. That's certainly not the case in Connecticut. So we still recommend doxycycline, 200 milligrams, if you remove a deer tick between 24 and 72 hours. Does doxycycline or other prophylactic drugs interfere with serology? Early treatment, if you're treating, say, a patient who has erythema migrans, and you're treating them early with, say, 10 to 14 days of antibiotics, that could have an impact on the serologic response. So I would say that is a possibility.
Okay. Someone else, why do you think Massachusetts case were so long on map? I quickly Googled updated CDC map if cases are high, speaking from someone who lives in Massachusetts. I'm sorry, she wanted to say, oh, why do you think Massachusetts cases were so low on the map? She quickly Googled updated CDC map and cases were high, speaking from someone who lives in Massachusetts.
I think I forget where Massachusetts stands in the ranking of states, but it's probably in the top 10 of prevalence. So I'm not sure why the map that I had shown didn't seem to show as much, but I agree that there are obviously a lot of cases throughout Massachusetts. And when I started practicing in Connecticut in 1977, cases in New England were confined to certain locations, like, as I mentioned, the lower Connecticut River Valley, Cape Cod, the islands off of the coast. a little bit on the North Shore of Massachusetts. But within a few years, Lyme disease migrated to Western Massachusetts and now covers the entire state. Moved up into Maine, and originally it was not in Maine, and then into New Hampshire, Vermont. When I first started practicing, New York State was limited to Westchester County, but now the entire New York State is covered with deer ticks, and it has to do with movement of deers and migration of birds, which can carry ticks readily as well. So Lyme disease is on the move. There are probably when you look at the number of reported cases of Lyme disease each year, most recently, there are about 80,000 cases that are either reported by physicians or laboratories every year. But this is an under representation. The actual number of cases is probably somewhere between 300,000 and 400,000 cases per year. Mostly again in the Northeast and the Mid-Atlantic states.
And I'm gonna allow Dr. Dorsky to he's gonna unmute and he's gonna ask you his question. I don't know if I was saying the word right, but I'm gonna let him just ask himself.
Hi, can you hear me?
I can.
Yeah. So I'm Dave Dorsky, ID in Westport, Massachusetts, southern Massachusetts, which is like a tick sanctuary.
Right.
Uh, the New York Times ran an article a couple weeks ago about a new kind of drug for humans. It's an ectoparasiticide called lotinolur. And it's taken weekly. It's proved in veterinary settings, and it can be taken weekly, and it prevents tick bites basically. And I was just wondering, what you're hearing, because you're more connected than I am. I mean, people are starting to ask about this because, I mean, where I live, ticks are tick bites are so common. It's really a health problem. And the idea of taking a medication weekly that, may or may not have a lot of toxicity, we don't really know. But I believe if there is an FDA in the future, that this is going to rise to the top. And I just wanted to bring it up, and maybe the official Lyme people like you will start thinking about it.
Well, I appreciate you informing us. I'm actually retired now.
Oh, okay.
Recently,
Well, you're in MAVEN, so yeah, me too.
So I'm actually, I subscribe to the Times Online, but I missed that particular article. So I appreciate, you letting me know. I'll have to go back in the archives and look that up. But what you're suggesting is that it's not yet FDA approved for humans, but it certainly sounds promising.
Yeah, well, again, I had never heard of it until I saw the Times article, and I've been researching it, and I just think that something like this may turn out to be more more capable of being introduced than a vaccine. And it's something you could take or not take, depending on what your exposure risk is at any given time. So
Right.
anyway, to be continued.
Yeah,
Thank
well, as I said, David, the Valnexa vaccine, the actual
Yeah.
Valnexa/Pfizer vaccine, will probably approved. It will probably
Soon.
be approved in 2026.
Yeah,
So,
and then there's the monoclonal antibody
yeah.
also. But I haven't even heard of someone getting that yet. So, all right.
That-
Thank you for your talk. It was very interesting.
Okay, and then I guess we'll have one more because we are past the hour. Someone asked prognosis for post-treatment long Lyme.
Well, similar to long COVID, in some cases, symptoms can persist. And, there's always a question when somebody has persistent mood disturbance, headaches, fatigue, whether you're sort of merging the physiologic with the psychologic, but these are real illnesses. And as you know from long COVID, some patients can be suffering for years, and it affects millions of people. And likewise, in long Lyme or post-treatment Lyme syndrome, this can continue. But most of the patients, at least most of the teenagers that I've seen in practice who have lingering symptoms, eventually get better. So I would say the prognosis is good after a year or two of symptoms.
Great. I don't see any other questions in the chat or the Q&A. I did put a couple of reminders in the chat. One of them is a reminder about the CME survey. It'll appear in a tab when you close out of this webinar. We really appreciate you taking the few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts. So thank you, Dr. Zemel, so much. Really appreciate it. It was a great presentation, and thank you everybody that attended.
Bye, Jennifer.
Have a great rest of your day.